For you guys who don't know, Robert is Dr. Cywes is a bariatric surgeon in Florida. He has a background, his Ph.D., I think, was in liver pathophysiology, so he's very well versed in liver physiology. He has taken a special interest in low carb, ketogenics, and now carnivorous diets. And so he is very pro carnivore and has quite a lot to say. He goes by Carb Addiction Doctor on his social media, I think on his Instagram, and so he has quite a bit of stuff to say about that. Oh, there he is, I think. Yeah, you're logging in two places. That's okay. Let me unmute you here. Dr. Cywes, can you hear me?
Hey, yes. Can you guys hear me?
I can hear you and both see you. So we're in business. Awesome.
Great. Yeah, sorry about the delay. I was trying a different computer, but it clearly failed. But if everyone can hear me, I'm good.
Yeah, I think I can. Can everybody thumbs up if you can hear Dr. Cywes? Hey, Rob, just a quick brief intro. I kind of talked about it already. I mean, you are a bariatric surgeon. You're located in Florida. Your wonderful accent is South African, which I am fond of because my mother was South African. Did a PhD, I understand, was it liver pathophysiology or liver physiology?
Yeah, it's liver transplantation, and that's really where we started to see the injury that sugar does to the liver.
Gotcha. Okay, well, so we have a bunch of people, they're all muted, but they're going to be typing in questions, and so why don't let me give you just a minute or two to introduce yourself for those who don't know you. I know you go by Carb Addiction Doctor on Instagram and your social media. And then we can maybe get to some questions if you're okay with that.
Yeah, that sounds perfect. I think I appreciate that introduction, Sean. I appreciate everything that you do. One of the key things, while I am a surgeon and I do bariatric surgery is really there for weight loss if you need it as a tool. In other words, if you've tried and failed to quit smoking many times, a nicotine patch, Chantix, may help you, but you've still got to crumple up the cigarettes and throw them away. On the other side is that a ketogenic approach or a low carbohydrate approach is the only way to be successful long term. And for me, the most important aspect is helping my patients to help themselves by getting rid of carbohydrates. What you eat on the other side can be debatable to discuss, but the quintessential starting point is to get rid of sugar and starch. And once we get rid of sugar and starch, we have to replace them with real food and also with the other purpose they served in our lives, which is as a drug from an emotion management perspective. And that's kind of my wheelhouse. So we focus very heavily on the addiction side of carbohydrates and then on the replacement both with food and an effective emotion management system. So along those lines, I'm happy to talk about any questions. We've been doing this for over 20 years, so there's very little we haven't seen or heard.
Yeah, I know you and I've talked personally about some of your experience with liver biopsies and that sort of stuff, but I'm just going to get to a question. I think this is an important thing because we have a person here saying, I had a friend who tried carnivore instead of doing bariatric surgery. She's doing amazing, one. And then she's talking about, she's heard the story of a friend who died from surgery. And I think that's sort of a misconception. Obviously, early on, the complication rates, mortality rates were much higher than they are today. Can you talk about the general risk of bariatric surgery? I know this is not the point of this, but I think that's, this misconception that everybody's dropping dead of bariatric surgery.
Yeah, I think far more people die of carbohydrate toxicity every day than have died ever of bariatric surgery. So putting it into context is important. And really the two roles of surgery is if you have a life-threatening disease such as a diabetes or a cardiac condition, or if you're just massively morbidly obese and you can't lose that weight. So you got to put it in the risk category. If you're just having it because you're a little fluffy, not a good idea. The risk that since we've been doing it laparoscopically has come radically down. The problem with bariatric surgery and surgeons like myself is that they're really good at weight loss, but they really don't understand obesity. Weight loss is about calories, and surgery is the most effective diet you can possibly be on. But ultimately, the issue with obesity and the type 2 diabetes as well is the behavioral aspect. And bariatric surgeons, because they're so good at getting people to lose weight, it's the most powerful diet you can be on, don't understand the behavioral change that people have to go into. So the greatest complication with any form of obesity surgery is weight regain. And 85% of people will regain some or all of their weight back in the ensuing 5 to 10 years. And that's a huge problem. But the surgical complications are very, very low. The other part that bariatric surgeons do, because they want to do the biggest bang for buck, they tend to do operations like gastric bypass and duodenal switch. And the trade in there is with a higher mortality rate, but also a higher risk of metabolic complications. And you don't want to trade in the disease of obesity for the disease of malnutrition. So to my mind, the better operations are the band or the sleeve. But at the same time, like that woman that you spoke about, Sean, if she's adopted a carnivore approach and she's lost a lot of weight, she's absolutely not going to need surgery unless she falls apart. So just briefly, I want to get to the questions. My personal story is that I topped out at about 300 pounds and I planned to have surgery, but I went low carb. I basically looked at carbohydrates from an addiction perspective. I've lost 90 pounds and this was 20 years ago. I'm still going to have my surgery. In other words, it's available to me should I relapse, but it's probably only going to happen a couple of minutes after I'm dead. And that's kind of my philosophical approach to my patients. So don't discard surgery, but if you're doing well, you certainly don't need it.
Yeah, I think that's a fair assessment. Somebody, and that's saying even a plate of broccoli sets off my carb sugar addiction. That's why I need carnivore. That's something that's just a comment there that I think is kind of interesting. And, I know there's people that talk about are vegetables bad or good, and that's a controversial topic. This is something someone talks to me. Can you talk more about pyroluria? Okay, pyrroles, I guess. One of my coaching clients is struggling with this, saying eating chocolate and sugar helps his depression. Any comments on that? It's kind of a odd.
Well, using a bit of heroin every now and then helps my depression for a few seconds as well. So what you're getting an endorphin rush from the drug. But the problem with things that we do for instant gratification, such as chocolate, such as sugar, is that you're chasing the instant high. You're chasing that instant gratification, that instant relaxation, that instant reward. The problem with that is there's a significant price to be paid on the back end, and it's negativity, harm, guilt. But more importantly, in the long term, in terms of depression, what we do is when we use a drug-like behavior to get that instant high, it ends up repressing the very issues in our lives that are causing our emotional tension. And if you don't connect with those issues, and it's difficult to do that, really what you need is some effort-based process. It might be going for a walk, it might be reading a book, it might be gardening, it might be a spiritual connection, it might be an empathetic conversation with a friend. When you put the effort in up front, and there's a time component to that. If I take my dog for a walk, the effort gives me the same endorphin high as that chocolate. But the difference is that because there's a time component, as I relax and I'm walking my dog, I can process and connect with the issues that are driving my depression. So by the time I come back from the walk, the reward on the back end of that effort is a good relaxed feeling, but also a connection with letting some stuff go, having a game plan for dealing with stuff. And if I connect with and deal with my issues more effectively, slowly over time, that depression eradicates itself. So I put chocolates and sugar fixes in the same category as having a cigarette, having a drink, shooting up with some heroin. Those are instant forms of gratification that leave us more depressed and more upset and more emotionally unstable than doing some effort-based activity to connect with your emotions and process them. Does that make sense to you?
Yeah, I think the questioner said that. Robert, I just want to take a half second to acknowledge that there is a fellow colleague, Phil Avadia, in the chat. He is a Florida-based CT surgeon. Do you know Phil? I don't know if you know him or not, but he's also.
I don't know Phil. No, do not.
So,
hey, Phil.
Phil is.
Hey, Bob. We actually met a couple of weeks ago in Boca.
Oh, okay. You look familiar to me. Yeah.
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 Anyway, Phil has been helping out tremendously with the site, helping our research library and stuff. So it's you guys, a fellow like-minded surgeon in the area that's also a carnivore proponent. Someone asked, Leah asked, what are the risks of a bariatric surgery versus prescribing a carnivore diet from a risk stratification standpoint? I think that's maybe a fairly
So,
question.
so it's like night and day. The carnivore diet is well, first of all, removing carbohydrates is the primary goal. The goal is to remove carbohydrates. The single best way to replace them, in my humble opinion, is with a carnivore diet. It simplifies things. There are zero carbohydrates when you're eating animals, or close to zero. It's the lowest carbohydrate consumption you can get. So the carnivore diet is the best replacement for carbohydrates in your way of life. And if you can sustain a carnivore way of life, but also develop a diverse skill set to manage your emotional needs through what you're doing, that combination precludes you from needing obesity surgery. So you don't need bariatric surgery if you can sustain it. The problem is if you keep going carnivore and keep relapsing and you lose some weight, it keeps coming back, or your diabetes keeps coming back because you relapse, that's when you consider surgery as a tool to help you towards sustainability. But the carnivore diet, as Sean knows, is we're only at the infancy. I would tell you this, that the carnivore diet hasn't been born yet if you put it into the continuum of human creation. It's still kind of a zygote because it's so fresh and so early that the majority of obese people, the people that mostly need it, haven't been on it long enough or haven't experimented with it long enough to recognize and understand the tremendous sustainability of the diet. In my own personal example, I was omnicarnivore through late last year, and I really went true carnivore at the beginning of January. And so it's very, very recent in our toolkit that we really have the comfort level of true carnivore. And that's where I'm so grateful to Sean, because Sean didn't tell me about the carnivore diet, but he proved that it was safe. And it's the safety of only eating meat that was always questionable in my mind. And now I'm very comfortable with it and have done the experiment myself. But the longevity of sustainability is going to be, I believe, the answer. And whether people use the carnivore diet to initiate a low-carb approach or they sustain it, the most important thing is that it's safe, and it is the answer, the antidote to needing bariatric surgery for most people.
Barbara Becker asked, what approach do you recommend to handle the emotional void that can be experiencing when giving up food for comfort? And this is very much in your wheelhouse here.
Right. Absolutely. And that's a great question. I mean, this is really what I talk about. So the reason we become fat or diabetic is not because we overeat. The reason we become fat and diabetic is because we increase, and let me just back up a little bit. When we talk about alcohol, the world has very tightly divided the liquids that we drink into water and water-like substances that we have to drink for hydration, and alcohol, which we primarily drink for pleasure. The human body has tight control over water. It doesn't have any control over alcohol. So you can drink alcohol to excess, you can't drink water to excess. The problem is, while we understand alcohol very well, the problem with carbohydrates is over the last 50 to 70 years, this highly neuroactive drug, and carbohydrates are a drug that we primarily consume for pleasure. They are not necessary for human survival, that the carnivore approach has clearly shown us. And excess is possible because there's no external control, and over time, excess causes harm. So what the world has done is blended carbohydrates under this common heading of food. That's like calling alcohol something we drink for hydration. And what we have to help people to do is to separate out food, which is what the body vitally needs, from carbohydrates that are a drug. And if the majority of the calories that you consume are carbohydrates, you're primarily using them for the emotional management rather than the nutritional value of what you're doing. Even if you're a vegan fruitarian, you're primarily doing that for the high that you get from it. But most people are either skinny and have never had the problem, or obese or type 2 diabetics where they've never recognized their emotional dependence on carbohydrates. Once you recognize that and you look at the harm that they've done, then you have to decide for yourself whether or not you love carbohydrates so much that you don't care if they're going to kill you, or you love them tremendously, but you care that they're going to kill you, and you get the restraining order and you kind of move out of that carbohydrate house. So that's the emotional management side. And by the time you're fat or diabetic, if you look in your emotion management toolkit, you've pretty much got carbohydrates and cobwebs. And if you remove the carbohydrates, if you're an alcoholic, if you remove the alcohol, you got nothing. And the goal is to develop a diverse system of effort-based emotion management skills and tools. The four cornerstones, there are four pillars. The first one is physical activity. It is ludicrous to think that physical activity has a role to play in weight loss. It does not have a direct calorie burning effect. Physical activity to lose weight is about as effective as smoking 3 cigarettes and going for a run to breathe out the nicotine. The goal of physical activity is as an endorphin alternative when you're not eating carbohydrates. Because people play games with carbohydrates and physical activity to their own demise. And I use the word physical activity instead of exercise because it's about the high that you get. It's about the pleasure that you get. And then that's the first pillar. The second pillar is the broad spectrum of creative arts. Things that we do in a creative way. It might be gardening, it might be fashion, photography, reading, writing, music, fashion. It's a variety of different things that we do that require effort and time, but that give us a wonderful sense of pleasure. The third one is spirituality or meditation. And spirituality is not necessarily going to church. It's prayer time. It's a connection with a higher power where you can share things that are you struggling with, and you can help yourself to sort them out in the presence of a higher power. The fourth one is empathetic human connection, where you have a tight human connection that is devoid of judgment or criticism. And you can take the risk of being vulnerable, of vomiting out certain things that you're not sure about or ashamed about into that empathetic space, and you can sort through it. If you have those four pillars as ways to effectively deal with your emotional needs, the issues that are troubling you, and you don't quantify the results or you don't quantify the process by some expectational result, it's about the pleasurable feeling. You no longer need carbohydrates in your life. And that makes, if you build that repertoire up over time, that makes the sustainability of a carnivore diet so much more effective, because the time you relapse away from carnivore is under sudden, unexpected emotional duress. But you've got to practice those emotion management skills on a regular basis to create muscle memory for them. Sean is not just going to get on his rowing machine on a rough day when he's stressed out, but he is going to get on his rowing machine when he's had a rough day because he gets on it every single day. I'm not suddenly going to go and walk my dog at night when I've had a rough day if I don't walk my dog every day. So it's building up the emotion management skills as a way of life, as a muscle memory way of life. Then when you need them, you don't go to the fridge and the pantry for ice cream or chocolates or mashed potatoes. You go for the walk, you go and paint, you go and garden, you have a prayer time, you talk with your close friend. So, and that process has no endpoint. The endpoint happens about 10 minutes after you die. And as long as you're continuously chasing more and more effort and time-based activities that you do for pleasure, the likelihood of relapse is extremely low. And that's the principle that we use. You can stop eating carbohydrates in a day, but effective emotion management strategy takes forever. Even the Dalai Lama is still learning how to meditate better.
Yeah, I think that's a wonderful addition to, obviously the diet physiology, but I mean, the psychology and the emotional support is also a huge part of this. And I'm so glad you're on here sharing this. Again, this goes back to more your wheelhouse, talking about somebody. Can you do carnivore is it good for people without a gallbladder? I've talked about before. Do you have a take on that without the gallbladder? Because I mean, I'm sure you're routinely taking out gallbladders as you do your bariatrics, or maybe you don't. I don't know. I know.
We don't take gallbladders out anymore with bariatric surgery, but I take gallbladders out all the time. Why? Because the majority of Americans are carboholics, and it is gallstones, the cholesterol gallstones, which is the commonest one we see. First of all, are not a function of overeating fat. There's a medical word I'm going to use for that. You may have heard me use this medical word before. I'm a doctor. I can. It's absolute bullshit. It's chronic excessive carbohydrate consumption. As that gets turned to fat by the liver, that produces excessive amounts of cholesterol that sediment out in the bile. So gallstones are a byproduct of carbohydrate consumption, not of fat consumption, because there is a concern that eating fat may cause gallstones. Absolutely not true. Quite the opposite. So that puts that concept away. The second concept is that by the time you have gallbladder disease, your gallbladder by definition is not working. So if you've got gallstones from your long-standing history with carbohydrates, and you're now using a carnivore diet, you're automatically eating meat and fat already with a diseased gallbladder. All the gallbladder does is it's a reservoir for bile, so that if you eat a lot of fat, a healthy gallbladder contracts, squeezes some bile in, and you need that bile to be able to absorb complex carbohydrates. Complex fats, longer chain fatty acids. And they get absorbed in the lower intestine in like the soap bubble that's made of bile, and they go actually up into the neck. It's the one nutrient that doesn't go directly to the liver. It goes into your general systematic system and goes directly to the fat cells. Nevertheless, if you've got a diseased gallbladder, that gallbladder has not been working for a long, long time. And if you've been eating fat, if you've tried a carnivore diet, it doesn't matter. If you take out somebody's healthy gallbladder, they may have a little bit of difficulty processing fat. They may have a little bit more diarrhea. They may have a little bit more cramping. And we see that with people with pancreatic insufficiency, for example, cystic fibrosis. But generally, taking out a diseased gallbladder has pretty close to zero effect on someone on a carnivore diet. It has pretty close to zero effect because the effect happened years before when the gallbladder got diseased. So this whole fearful concept that a carnivore diet is going to be terrible after a cholecystectomy is absolutely not true. And in fact, if you're having a gallbladder removed, it is another testament. Now you're having a surgery because of your addiction to carbohydrates, and that's not a good thing. So we actually use a carnivore diet in preparation for people having a gallbladder surgery to shrink their liver down, to get their liver nice and firm so that I can remove the gallbladder without bleeding and without other issues. But not at all. Having a gallbladder removed or having gallbladder disease is absolutely not a contraindication to a carnivore diet. One other comment, if you do eat some fat after your gallbladder surgery is out and you get a lot of diarrhea, guess what? Back off a little bit on the fat and slowly train your body over time to accept that carnivore diet again. But an indication after gallbladder disease is a carnivore diet, not a contraindication.
Yeah, Robert, a couple of just interesting points there. I've seen somebody talk about the common bile duct will sometimes expand chronically after over years and act as sort of a kind of a temporary reservoir, kind of a pseudo reservoir, a pseudo gallbladder. And the other thing is, we had Paul Saladino, and I talked to him the other day on a different podcast, and he was speculating. This is based, I think, on some rodent studies that possibly gallbladder disease or gallstones might represent a deficit or a deficiency of choline or phosphatidylcholine, which we obviously get from animal-based foods. Any comments on either of those two things?
I think that's a reasonable hypothesis. I think that's not an unreasonable question to pose. But remember, a lot of people who eat a lot of carbohydrates still eat quite a bit of meat. So I do not have any data to support that. However, the lab I did my Ph.D. in was actually at a guy called Steve Strasberg up in Toronto, Ontario at Mount Sinai Hospital. And their whole work was gallstone disease. And the misnomer was they were looking at the consumption of fat toward cholesterol gallstones. And they were never, ever able to put their finger on what it was in fat that caused gallstone disease. And the reason why is because fat doesn't cause gallstone disease. Once we demonstrated, my PhD project was showing how the liver handles fat. And actually, I came at it from an erroneous perspective, but we now know that it's the conversion of sugar to fat and to a variety of fats. Remember, a lot of cholesterol is actually manufactured in the liver, and it's that supersaturated cholesterol that comes from the conversion of sugar to fat that saturates the bile and we know now with definitive knowledge causes cholesterol gallstones. Whether the choline is a piece of it, I don't know, but I certainly would support the hypothesis that a carnivore diet is not harmful. It may be helpful. And you're absolutely right about the dilation. it is normal after cholecystectomy to see a dilated gallbladder. That is a completely normal thing. And whether it's a reservoir for bile or whether it just allows a much more rapid release of bile from the liver into the intestine when you eat, I don't know, but it doesn't significantly affect bile delivery. So nobody gets these floaty poops when you eat a lot of fat like we used to with the weight loss medication called Ali or Orlistat, which was a fat blocker, and the side effect of that was fecal seepage. Now, we see guys like Joe Rogan and those guys have a little bit of that early on when their body's not used to it, but pretty quickly that goes away. Exactly the same after cholecystectomy. The fecal seepage goes away.
Jill's asking, she says she has a patient who had a Roux-en-Y gastric bypass, now has difficulty digesting red meat due to low stomach acid. I'm not sure, would a Roux-en-Y necessarily mean low stomach acid? I'm not sure on the why that would be the case, or is that just a coincidence?
Yeah, first of all, the majority of my patients are already on proton pump inhibitors, Prilosec and that kind of thing, and they've got low, they have a deficiency of gastric acid anyway. So just based on that, I don't buy that argument. In fact, if you have a gastric bypass, the acid production in the lower part of the stomach is still there, and it does run through the bile system, but connects with the food at a much, much lower level. However, it's already neutralized by bile. So there may be a plausibility there, but here, I don't believe, and certainly in my gastric bypass population, I have seen zero issue with the processing and the metabolism of fat. Yes, by intention, the gastric bypass and the duodenal switch is intended to reduce the time frame that people can process meat of any sort, and that's fat and protein, and they do poop quite a bit of that out. That's the problem I have with the duodenal switch and the bypass, but that's a malabsorptive situation, not a gastric acid situation. That just means that you've got such a short intestine, you don't have enough time during the passage of that food through your intestine to break it all down and absorb it. But I don't believe there's any evidence to support the fact that it's related to acid suppression, because otherwise I believe the proton pump inhibitors that get used in reflux and acid patients would have the same effect. But I do think it's part of the malabsorption. But here's the point, Sean, I think you know that. Human beings are genetically designed to eat meat. So it is counterintuitive, except in very, very few instances, that meat actually causes us problems. To my mind, the problem in a bypass patient who doesn't want to eat meat is more up here than it is down here. And in my patient population, I've never seen anybody who was not able to eat meat unless there was a stricture that prevented the meat from going through the intestinal tract. But there's no biochemical reason why they shouldn't eat meat.
Yeah, no, I can see that. Here's this is kind of an interesting question. This talks about, can you talk about adjustments you had to make for someone who's had a while on with a radical gastrectomy and 80% removal of pancreas to address stage 4 gastric carcinoma? Sounds like a Whipple procedure, if I'm not, if I'm remembering my general surgery. But is there anything you have to do different? I mean, because what deficiencies somebody that has either a gastric sleeve or something like a Whipple or Roux-en-Y going to have just from the surgery, and how do we deal with it?
Well, there's two separate things here. The operation that I like the most is the sleeve gastrectomy, because it is purely a restrictive operation. It only reduces your caloric consumption. What you put in your face, you will absorb, because it doesn't alter absorption at all. So the responsibility is then on the patient to put appropriate food, not drugs, into their face, and do it intermittently, not continuously. So the sleeve is the operation that the sleeve, and maybe in the old days, the lap band, which are purely restrictive operations, not malabsorptive operations, are the best set of operations. With the bypass and the switch, you're pooping out a lot of the calories, but you're also pooping out a lot of the nutrients, and they are operations of malabsorption intentionally, which is great for weight loss, but not so good for metabolism. However, you asked a completely separate question. In somebody who does not have a pancreas, the pancreas is the primary place where we produce the enzymes that break down real food. So we produce the enzymes that break down fat and break down protein. And also the pancreas is the place that we produce both insulin and glucagon that regulate our blood sugar, both in the production of sugar from the pancreas, from the liver, as well as the removal of sugar from the bloodstream and the regulation of glucagon. So the pancreas is really a very, very important organ. And if you've had a Whipple operation or a total pancreatectomy for cancer, or in children we sometimes do nocidioblastosis, the two diseases that you are going to get, depending on how much is removed, is number one, diabetes, type 1 diabetes. And if the total pancreas is removed, the type 1 diabetes is actually not that bad because you don't have glucagon as a producer of sugar. So your sugars don't go really high, but you have to have insulin. Because you're not able to produce enough insulin. The second group of enzymes, not the hormonal side, but the enzyme production that goes through the pancreatic duct directly into the intestine, are primarily the fat breakdown and the protein breakdown enzymes. And under those conditions, if you've had a total pancreatectomy, or if you've got a disease like cystic fibrosis, you still want to eat the animal products, but you may need to take enzymes in a capsular format. And on my patients that have pancreatic insufficiency, whether they were alcoholics, whether they've had surgery to remove their pancreas, alcoholics, chronic pancreatitis, or whether they're cystic fibrosis patients, we have a very, very effective metric to supplement their enzymes with pancreolipase and pancreatic enzymes that produce normal metabolism of those substances. And in fact, in those patients, I particularly like a carnivorous or a very close to carnivore diet because it is so much easier to regulate. You can regulate the amount of enzyme that they need to consume directly by the amount of food that they eat. And it's kind of a 1-to-1 ratio. So it helps me tremendously in my pancreatectomy patients to manage them more effectively with both insulin as well as with pancreatic enzymes. And their insulin utilization can be very, very low, but they absolutely do need to be on insulin because they are type 1 diabetics. But on the carnivore diet, you can get your insulin utilization, I look at C-peptide, to below 1.0, which is almost unheard of in the modern American population because your insulin sensitivity goes through the roof and your insulin utilization is extremely low. So it's a great way to go.
Hey, Paul, Rob, can you talk, I know we've talked about this extensively, a little bit more about fatty liver. Let's talk about fatty liver because you see that every single day, and talk about how a carnivore diet or a low-carb diet, because a lot of people talk about fatty liver and you're going to get a fatty liver eating a bunch of fat. What has been your experience as someone who actually biopsies livers every single day?
Yeah, thank you, Sean. That's such an important question because fatty liver is something I see every single day in the operating room. And one of the key things when we do foregut surgery, when we do surgery toward the upper part of the abdomen, the liver is this massive organ that sits right in the front. And one large carbohydrate meal can swell the liver up to 6 times its normal size. It isn't just the calories or the sugar that you're eating, because sugar is very hygroscopic, it sucks up water. So not only does the liver get very large, it also sucks up a lot of fluid. And when you try to, at surgery, when you try to lift those big swollen livers up, they look like jello. And they will rupture on you, they'll bleed, they'll make the surgery very, very difficult. And what I found very early on as a surgeon is that what most doctors think is that it's calories. So they put their patients, their bariatric surgery patients, on a low-calorie diet. And a very low-calorie diet will shrink that liver down to a certain extent, but it's still soft like jello. And in my work that I did in the lab, we demonstrated in 3 hours, I can create a fatty liver just by infusing sugar into the liver. So 3 hours of carbohydrate production, I can swell the liver up to 6 times its normal size in an isolated liver on a floating machine. When I gave those same livers amino acids, there was no effect. There was zero effect in terms of hepatic steatosis. So that was something I demonstrated in the laboratory as a PhD student. Now, in my own patients, when I'm operating on them, I'll tell them this. I give them a diet sheet about 7 to 10 days before the surgery, and I'll tell them this. You can eat a cow a day. Your liver will be absolutely fine. The critical thing is, don't even look at a carbohydrate. And in my practice over the last 20 years, we've biopsied close to 9,000 livers. I biopsy the liver every time I'm in there. And if a patient has religiously avoided carbohydrates for those 7 to 10 days before their surgery, their liver shows zero evidence of hepatic steatosis. They have no fatty liver. By definition, all of my obese patients come into my office for the first time with these enormous fatty livers that you can test on ultrasound. So they can eradicate fatty liver syndrome by eating as much cow as they want to, as much bacon as they want to, but zero carbohydrates. So about 20 years ago, we adopted a model of feeding our patients as much as they want to, because let's face it, an obese person loves to eat. Let them eat, but no carbohydrates, and the fatty liver goes away. So to answer your question quickly is that it is not fat that causes a fatty liver. The two elements that cause a fatty liver is alcohol and the consumption of chronic excessive carbohydrates. Those two things. So we've got fatty liver, alcoholic steatohepatitis, inflammation, and fatty liver from alcohol. But the commonest cause of a fatty liver in America and probably in the world is chronic excessive carbohydrate consumption. No carbohydrates, no fatty liver. It is completely reversible, and it is curable as long as you don't eat carbohydrates. But one large carbohydrate meal will swell your liver all the way back up. And that I've demonstrated over and over and over again, visually and by biopsy in the operating room. And I'm absolutely adamant about that.
Yeah, that's fascinating to see, and I've seen it, time and time again. People getting ultrasounds after they go on a carnivore diet, and their previous, NFLD is gone. There's some.
Let me just interrupt you for 1 second there. What's amazing for me is that I can get somebody to eradicate the fat from their liver, to basically put fatty liver into remission within 3 days. 72 hours on a zero carbohydrate diet, fatty liver is gone. Particularly if they do just a little bit of physical activity, like going for a walk or whatever it is. In other words, make demands of the liver to release a little bit of that glycogen. So within 3 days, we've demonstrated over and over again that we can put fatty liver into remission.
Someone is, and this is maybe a little outside your realm, but well, actually, no, I'll get this one first because it was a good one. Somebody was asking about, what do we do with people with eating disorders? And obviously there's people that restrict, and there's people that chronically are food addicted. Is surgery the only option for them? How do we deal with that? Is that where surgery would be the case where you just can't? Is there anybody that's so far gone with either food addiction or eating disorder that you can't rescue them without surgery?
First of all, if 75% of Americans are insulin resistant, by definition, the commonest eating disorder is insulin resistance. And whether that translates into obesity or diabetes doesn't matter. That is in and of itself a subconscious eating disorder. Now you can go down binge eating and all the others, but ultimately that is your eating disorder, period. Surgery is not a cure for a behavioral disorder at all. Surgery is a cure, while it's working, for chronic excessive calories. So in other words, surgery is weight loss. Surgery does transiently put diabetes into remission in the same way a diet does. But the way I divide it up is into two completely separate categories. Surgery is about caloric reduction and a loss of calories and a loss of pounds in the identical way that any diet is a form of caloric reduction. However, obesity and eating disorders are behavioral problems that are not calorie-based. They're carbohydrate-based. And no surgery will ever fix a behavioral disorder. The work has to come from an addiction management system, a removal replacement system to effectively address the eating disorder. And whether that is insulin resistance, whether it is binge eating, whether it is chronic excessive carbohydrate snacking disorder, it doesn't matter. Those are all emotion management dysfunctions. And ultimately, someone who has an elevated insulin level, whether it, and one of the key things about insulin levels is I call it high insulin levels because some people are insulin resistant toward obesity and some people are insulin resistant toward prediabetes. And that's genetically based. We can talk about that if you want to, but ultimately those people cannot be helped long-term with a diet. They can be helped with behavioral management. And a diet is really just what you use to correct the metabolic dysfunction, while the behavioral part corrects the bigger dysfunction, which is above the brain or in the brain.
We'll shift the gears here, Robert. There's somebody who's asking about what do people do that either have had their thyroid surgically removed or radiation that's basically ablated the thyroid. Is that something you can discuss? I know you.
Yeah, absolutely. As a surgeon, we do that a lot. We remove thyroids for cancer, for a variety of benign disease as well. Graves' disease is one of the common ones. Goiter's is one of the common ones. So, and even if you don't have your thyroid removed, you may have certain thyroid diseases that require suppression of thyroid function. So there's no question, and we're talking about the thyroid. I'm not going to discuss the parathyroids in this, although we can. The beauty about the thyroid gland is we understand it pretty darn well in healthcare. And if you either need to suppress your thyroid or you need to replace your thyroid, there are great medications to replace them. You can use T3, you can use T4, Synthroid is T4, Armour now is a combination of T3 and T4, and by testing your blood, we can measure the efficacy of that replacement very, very well. So thyroid hormone replacement is very well worked out in healthcare, whether you've lost your thyroid or just need to suppress it. I'm not concerned about that at all. There are two concerns that I do have, and the thyroid hormone does affect metabolic rate if it's high or low, but here's the point, and this is what I tell my patients all the time. Two things. Number one is metabolic rate. You never have to metabolize what you didn't eat. Your body knows best, and you don't have to metabolize. If your metabolic rate is low, you're going to eat less if it's real food. If your metabolic rate is high, you're going to eat more. If you've been exercising, you're going to breathe harder. If you're just sleeping, you're going to breathe a little bit less. Your body is very responsive in that regard if you're eating meat. However, if people tell me that, oh, my thyroid might cause my obesity, I ask them for this. I ask them, the next time I see you, please bring me videotape evidence of little hands coming out of your neck, picking up cake and putting it in your mouth. If you can show me that videotape evidence, then we'll blame your thyroid for your obesity. Thyroid hormone dysfunction does not cause obesity. Now, on the flip side of that, there are certain thyroid diseases that may be related to elevated levels of insulin and elevated levels of inflammatory disease, which comes from the consumption of polyunsaturated fats or industrial fats, as well as chronic excessive carbohydrate consumption. And we know that some of the autoimmune diseases, particularly Hashimoto's, is heavily affected by, or may well be affected by, an inflammatory response. It's an autoimmune disease. And we have seen some of our Hashimoto's patients be able to, if they're hypothyroid, be able to produce enough thyroid hormone to come off their medication. But that's an experiment that takes a physician to help you with, because your thyroid has to recover over time. And there are a lot of thyroid conditions that, well, let me back up a little bit. The tough part about modern medicine is that we no longer, for the most part, understand or look for the cause of a problem. Most family doctors will do a panel of blood work once a year, and if they see that your thyroid hormone is low, their diagnosis is low thyroid, and they stick you on a thyroid medication, often Armour, without ever understanding why your thyroid is low. Over 70% of the patients that walk into my office to begin with are on some form of thyroid medication. One of the most common sources of thyroid disease is hyperinsulinemia. And what a lot of people don't understand is that T3 and T4 is one of the common steroid precursors. Did you know that T3 and T4 starts out as cholesterol? And through a series of enzyme pathways with iodine and a few other manipulations, it becomes T3 and T4. And actually T4 then becomes T3. So the common precursor is cholesterol, and insulin is one of the hormones that downregulates high levels of insulin, downregulates one of the first precursor steps of the conversion of cholesterol downstream. That's one of the reasons we see polycystic ovarian syndrome, we see low testosterone, we see cortisol affected, we see human growth hormone affected, we see D3 cholecalciferol affected, we see T3, T4, and we see bile, which is the absorption of vitamins A, D, E, K, all affected in a negative way by hyperinsulinemia blocking the first stage of the conversion of cholesterol downstream to those hormones. So it doesn't just affect the thyroid, it affects all of those other hormones in people who are high producers of insulin under the influence of chronic excessive carbohydrate consumption. And most doctors don't understand that. They don't understand the precursors of those steroid hormones. So if you have hypothyroidism, you need to know why. You need to have a diagnosis. Is it Hashimoto's? Is it Graves'? Is it a cancer? Have you had surgery? Why do you have low thyroid function? Because if you don't understand the cause, you can't get effective treatment. Does that help?
Yeah. This is from Max Palmatier. You know, there's something I saw today on social media. There's a doctor who's fairly popular on social media at the UK. He put a big thing that said, food cannot help with cancer, and food does not cause cancer. And Max says, do you see signs of liver cancer ever? And do carbs affect liver cancer as well? I know this is a controversial topic. Do you care to weigh into that?
Well, you know, I agree with the fact that we really don't have evidence that diet causes cancer unless you're consuming a toxin. But can it modify the inflammatory response that is the trigger for so many cancers? Absolutely. There is strong evidence that it does. And we've seen that with particularly with brain cancers and with some of the soluble cancers like leukemia and lymphoma. One of the interesting things, and I'm not an expert on this, but I've been to a number of talks, and this is something that really resonated with me, is that there are a number of cancer cells, and cancer cells are voracious in their appetite for energy because they're continuously multiplying and growing. And one of the interesting things is a doctor a little bit ago was giving a talk about mitochondria, and that in certain cancer cells, the cancer cells are glucose obligate. In other words, they have to have sugar as a source of energy for themselves, and they're not able to use ketone bodies, or their ability to use ketone bodies is significantly downregulated. So while I don't believe that food in the diet, now for the sake of this, I'll put sugar in there, although sugar is a drug. I don't think that it causes cancer. It can definitely modify the inflammatory and cancer response, and also the diseases or the conditions that are what we call the paraneoplastic conditions, the conditions that we suffer that are not directly due to the cancer, but due to some of the changes that the cancer makes. Be they cachexia or loss of weight or a variety of other inflammatory responses. So the reduction in carbohydrate consumption and the increase in a carnivorous diet is probably the single most effective thing that you can do for yourself to reduce the inflammatory response. And one of the key things about inflammation is mediated for certain cancers by the type of fat that occurs in the mitochondrial and cell membrane. So that fats that have a number of double bonds, it's so-called polyunsaturated fats that primarily come from industrial fats and from the conversion of sugar to fat. Those fats have a lot of double bonds. When they get inserted as phospholipids in the membrane of your cells, those bonds are very unstable. And those double bonds break. And when they break, they release oxygen-free radicals. They release carbon monoxide and peroxide and oxygen-free radicals. And that is inflammation at a molecular level. And there are certain genes, as far as we're aware, the HER2/neu gene, the BRCA gene, which are the genes that go toward breast cancer, are activated or triggered by that chronic inflammatory response. So there's a change in the regulation of cell division by the BRCA and the HER2/neu genes. I don't understand it completely. I've read enough about it, but I tend to forget it from time to time. But what happens is those genes are no longer adequately regulated under the influence of that inflammation. And that causes the breast cancer, the Angelina Jolie type breast cancer. And if you significantly reduce the inflammatory nature of the phospholipids, of the fat in your cells, and have a significant cholesterol component to those, remember, about a third of the cell membrane is made of cholesterol. If you significantly reduce that inflammatory component, both from carbohydrates and the consumption of polyunsaturated fats, you reduce the inflammatory response, you reduce the triggers for cancer, and you also reduce the cancerous multiplication by radically reducing this chronic excessive amount of sugar they have access to. Of course, those cells are still going to have some sugar access because you do maintain your blood sugar. But if you drop your blood sugar down to basal levels, 70 to 80, I believe that there is a benefit to those obligate cancer cells. So there's no question that more of a lower inflammatory diet, such as a carnivore diet, has an impact on reduction in cancer rates and cancer growths. I'm not sure it triggers cancer specifically.
Bro, I don't want to tell you much time, so I see you're in your scrubs, and it sounds like you've got to get back to work. But somebody asked me, this is a kind of a general topic. What are your thoughts on the sort of very prevalent push to make us all go plant-based?
I think it's great for the planet because the planet has too many people on it. I just wish that the plant-based diet would have a negative effect before people procreated. No, that's a little bit facetious because that's a Darwin moment. Sean, with deference to you, if you are plant-based or carnivorous, it probably is less important than whether or not you eat carbohydrates. In other words, if you look, the analogy I use is that what air is better to breathe? The air in a valley in the Rocky Mountains or the air in Times Square at 4 o'clock on a Friday afternoon? Well, clearly the air in the Rocky Mountains is cleaner than the air but it doesn't matter if you're still smoking. The greatest threat to our health and to our lives in this country comes from sugar and starch, from carbohydrates. And the most important focus has to be on removing carbohydrates in the abundance in which, and the prevalence and the snacking nature by which Americans and people all over the world consume them. Then, once you've done that, then we can argue vegan versus carnivore. And the way I pitch it to my patients is this: a vegan diet, in my opinion, is a diet of deficiency. In other words, if you have to go to GNC as your food store, you're not on a complete diet. But if you are vegetarian and maybe you eat a little bit of what I call renewable protein, cheese and eggs, and maybe some fish every now and then, which is not renewable, you're probably metabolically going to be okay. But there are a number of things in a plant-based diet that could be healthier or could be triggers for more subtle diseases, oxalates, that kind of thing. The one thing we know for sure is that biologically and biochemically, and the way the human body, the GI tract in particular, is adapted, and most importantly, the needs of our brain, the single best diet to be on is a pure carnivore diet. So is it healthier to be on a carnivore diet versus a vegan or vegetarian diet? Biologically, and I want to get way away from the emotive argument, biologically, the benefit is, and our entire evolution has been toward more and more animal products, primarily for the type of fat that's in there. And you just don't get the same amount of fat or amino acids from a vegetarian diet as you do from a carnivore diet. And that's primarily mental health, because our brain is our greatest resource. As much as you work out, Sean, you are pathetic relative to a lion, because a lion uses its body to chase its food, but you have a brain and you've got hands that can use weapons to access your food source. And that's what separates us out. So really what separates us as the apex species is this, not this. And that primarily comes from a high-fat diet. And there's just not sufficient fat in a plant-based diet to support that. And can you stay alive? Can you stay healthy on a plant-based diet? Absolutely. And I don't think we should argue that. But from an evolutionary and a Darwin forward movement perspective, the migration is more and more toward brain health and toward longevity. And you want to avoid Alzheimer's, you want to avoid what I call type 3 diabetes, Alzheimer's, dementia, and Parkinson's. And those all come from an excess of carbohydrates and a chronic deficiency of saturated fat and 3 and 6 omega fatty acids. So to my mind, the focus has to be on eradicating carbohydrates as a primary food source or drug source. Whether you go vegan or carnivore, if you can avoid the carbohydrates, I don't mind, but the shift in terms of optimal health, there's no question in my mind that it is animal-based, not plant-based. Does that make sense?
Yeah, it does to me. It does to me for sure. Obviously, I share the same sort of sentiment. I don't know how much more time you have, Robert. We've been an hour. I've got a couple more questions. Do you?
If you want to go ahead, I've got a few more minutes. I am operating. I'm going to stamp out obesity this afternoon with a scalpel.
All right. Okay. Heal with steel, man. I know.
Yeah.
There's somebody asked about what about people that are on psychiatric meds, antipsychotics. I would put antidepressants in there. Does that have an effect on how we manage their emotional addictive behaviors? Does it affect the physiology? What would you say about that?
Well, I mean, it's a good question. The majority of the reason, there's two classes of reasons why people are on psychometric medications. Number one, they have an organic disease. They may be bipolar, they may have schizophrenia. Those patients need their medications. Go to your psychiatrist, get on your medication. Therapy may or may not help. The majority of people in this country and probably the world over are on psychoactive medications, antidepressants, whatever it may be, because they have profound deficiencies in their emotion management system. And just like we put people on thyroid medication to deal with a low thyroid that comes from their diet, just like we put people on vitamin D because they're not either getting enough D in their diet or insulin is blocking the use of D, we put people on antidepressants to deal with their depression. Everybody gets depressed, but because they don't have any resources to help them to deal with their emotional management system. So while we talk about deprescribing diabetic medications and blood pressure medications fairly freely, the whole context of deprescribing some of the antidepressants in particular is something that I take a lot of pride in, is that when people have built up a sufficiently effective, diverse, action-based or effort-based emotion management system, we slowly wean them off some of their antidepressants. And the majority of those patients can come off and stay off those antidepressants and anxiolytics because they've developed better coping skills. So the entire wheelhouse of what we do is geared toward better emotion management. So, and the best way to do that is, again, on a carnivore diet. It's carb-free. Those folks will relapse on whenever they get depressed or anxious. Look, let's face it, Sean, everybody gets depressed. Everybody gets anxious. The question is whether you stay there because you don't have the tools to dig yourself out of that hole, or if you eat carbohydrates because you're depressed or because you're anxious, or if you go for a walk, go to church, talk to your friends, if you use those skill sets to be able to recognize and get yourself out of the hole of depression or that mental illness that you caused. So almost everybody that comes into my office has anxiety, depression, frustration, anger management issues. And as you develop a better, diverse skill set to handle them, you no longer need the drugs. Does the condition still exist? Of course it does. It's one of the emotions that all human beings feel, but it's a transient thing that you can resolve very quickly when you have the tools, as opposed to something that takes over your life. So a large part of our carb addiction wheelhouse is managing those patients holistically, not just their weight, but also the depression, the anxiety, the mental health that might have resulted in that. Ultimately, the best weapon against those mental health issues is healthy parenting.
Well, some of us are too far beyond to be parented at this age. I mean, most of us are 50, so parenting is not an option for us. But hey, let me ask this as another question. This is kind of a blend of a couple questions. People are asking about your thoughts on what role does fasting have? And there's a difference between people that maybe eat every 12 hours versus people that'll spend a week or 2 weeks fasting. What are your thoughts on that with regard to emotion, weight loss? Does it have a role? Does it not have a role? Is it context dependent? Versus like a carnivore diet. How do you see fasting in that role?
Okay, I love Jason Fung. I've written a book with him. I've known Jason for a long time. Fasting is probably the single worst thing that anybody can do to their bodies on a consistent basis. However, not eating for long periods of time is one of the best things you can do to your body. And the difference in my mind is this. Yeah, sure, if you're diabetic or if you're morbidly obese, and Jason's primarily is a nephrologist, primarily started treating diabetes, intentionally fasting, taking the risk of tapping into your body's long-term stores in order to eradicate very quickly a very, very bad disease is excellent to begin with. So if you're a diabetic at risk of going on dialysis, if you're a diabetic at risk of losing a leg, fasting is one of the best ways, in other words, protracted periods of time where you're not eating, one of the best, quickest ways to restore a semblance of insulin sensitivity. But what we're talking about here is a long-term sustainable approach. And the approach that we've taken in our practice over the last 20 years is not to institutionalize fasting as a intentional, conscious concept. What we just educate people to do is if your body doesn't need food, don't eat. And whether that's 6 hours or 12 hours or 24 hours, the human body or the body of every animal eats, obviously with availability of food, eats when it needs to and doesn't eat when it doesn't need to. And that's kind of what we want to do. We want to get away from the institutionalization of specific meal times and this ridiculous emotion management system called snacking. But the beauty about going carb-free is that your body the blood sugar doesn't go up and down. It kind of levels off so that drop in sugar doesn't trigger hunger. And you can go a very, very long time without eating, but it's not fasting. It's just not eating because I don't feel like it. Basically, I'm not eating right now because I'm not fasting. Fasting is an intentional thing that is overdone to tap into your body's long-term reserves. Not eating taps into your short-term stores. And if you're obese, that excess fat that you have is just a short-term store. It is not something your body depends on to be alive. In the modern era, we certainly don't need to accumulate a lot of fat because of harsh winters. So we have a ready supply of food source. That's what the modern era post-hunter-gatherer has done. So I don't think that fasting on a regular basis long-term has health benefit. In fact, I think it is a liability to those long-term stores, our muscles and other things. However, not eating for protracted periods of times happens automatically on something like a carnivore diet. All you've got to do is open your mind to the fact that it's okay if I don't eat breakfast or lunch, or if I go a whole day without eating, I know tomorrow I'm going to eat because I need some food. And I think that we have to open our minds to protracted periods of not eating, but I don't think that intentional fasting over a long period of time, early on, sure, to get into ketosis, sure, but long-term as a lifestyle, not a good idea. Now, one other thing, you see me drinking, this is my mug of coffee, and it's black coffee. I'm not drinking that. Thank you. Hey, Philip. I'm not drinking that because I'm thirsty. I'm not drinking that for hydration. This is what I call a bridge. This, when I was fat, used to be M&Ms and a can of Coke. And the difference between a bridge and a snack is both of them are emotional events. I'm sipping on that coffee just to give my mind a few seconds. It's a mind cleansing moment to allow a little serotonin hit in this spread of dopamine focus. If you listen to some of those talks of mine. But the difference between my coffee and M&Ms and a Coke is the M&Ms and a Coke gave me that emotional reprieve, but also caused me harm. My coffee gives me the same emotional reprieve because I've developed it as a relationship without causing me any caloric harm. And that's the difference between a bridge and a snack. So if you want to count this as a meal, knock yourself out. But I think being puristic in terms of what we're doing is sometimes perfection can be the enemy of good enough. So I typically plan 1 or 2 meals a day. And if I get to a mealtime and it's not a moment that I'm going to do, like right now, this is supposed to be lunch, but I'm busy. This is my lunch. I'm having a mental lunch, not a calorie lunch. And I will survive until dinner tonight without consuming calories. I've got enough stored, I'm fine. That's my not eating. I don't believe that fasting intentionally is a sustainable long-term method.
All right, great answer. Hey, get one more topic, and then we'll let you go because I have to go too. So
Yeah.
I want to, as a liver specialist, you've probably touched on this concept of hemochromatosis, iron overload, deposition in the liver. There's some concern with a red meat diet being high in iron, lots of heme iron. My looks into this, I've looked at hepcidin, which helps us regulate iron absorption, which is produced by the liver, and then the fact that insulin seems to have an impact on that. Any thoughts on or concerns about people getting overloaded with iron by eating red meat? Is it more a metabolic problem where people have iron storage issues or something? Or can you talk about that at all?
Yeah. So hemochromatosis is a very specific enzymatic deficiency disease. It is a disease that occurs at birth, and for the most part, under age of 10, if you look for it, it can be diagnosed. It is accumulation of excessive iron because of an enzymatic processing deficiency in the human body, and iron deposition occurs in most organ tissues. So that is a specific disease. It is a genetic condition, and that is what hemochromatosis is. By far the commonest disease from the iron spectrum in America is anemia. It's a lack of adequate iron. Whether you're a woman who's got polycystic ovarian syndrome and you're losing tons of blood in your periods, whether you've got gastric ulcers, or whether you're not eating enough iron, that's a far more common disease, often related to losses rather than consumption of iron. I have never met a lion that has hemochromatosis. I have never met a dog that has hemochromatosis. And probably this, why do I bring up those animals? Because dogs are probably the most closely related to humans in terms of the enzymatic nature of how our intestinal tract works. And dogs do not get hemochromatosis. So the human body is very, very adept at excreting excess iron and handling excess iron as long as it does not have a genetic defect. So that fear is irrational. The other part also that's true is this, and one of the reasons I love the carnivore diet, which is really a high-fat diet, and protein comes along for the ride, it's not a lean protein diet, is this, that by definition and by design, by genetic and hormonal design, fat regulates the consumption of fat at various levels throughout the intestine, as well as in our fat cells, sends out a hormonal message to tell you to stop eating when you've had enough. In other words, biologically, the body is designed to regulate enough is enough, and you won't overeat meat. If you could overeat meat, people would become obese from eating carnivore, and quite the opposite happens. So can you maintain your weight on a carnivore diet? Well, Sean is a testament to that, but Sean will never ever be fat if he stays on a carnivore diet. So the human body is biologically designed to regulate that. And when it comes to iron, exactly the same. It won't allow you to consume excessive iron. Now, the one thing I will tell you is that if you go on a no carbohydrate or a carnivore diet, very rapidly deprescribe all the supplements that you're taking. Because if you're still taking iron and you don't know what your iron indices are, you may get into trouble, but that's supplementation rather than iron. So in my experience over 20 years, I've never ever seen hemochromatosis, and we measure it all the time. I mean, I've got 30,000 patients worth of blood work, and we just don't see iron overload. We don't see ferritin, transferrin, iron indices, hemochromatosis, or excessive hematocrits, which are the results of, in part, excess iron. We just don't see that in otherwise normal people, including people on a carnivorous diet. So that is a complete myth that is used to substantiate that eating carnivore is not a good idea. The body cannot eat too much meat. It won't allow you to, not over time.
Robert, thank you so much for coming on. I think I speak for everybody in the group today that it's been really enlightening and wonderful, and it's certainly our pleasure. Hopefully we can get you back on down the road. I know you got a busy schedule and a busy day, and I appreciate you taking the time. Thank you for what you're doing to help. We're in the minority of the people that are fighting against what seems to be a march towards human destruction, for lack of a better word. So I appreciate it.
No, I agree completely with you. Thank you very much, Sean. And I do have to run, but I just want to ask people, if you wouldn't mind, if you've seen some value in this, or you want to learn a little bit more, particularly about the addiction side, my YouTube channel is called Carb Addiction Doc, D-O-C. It's free, but I would really appreciate it if you guys could hit the subscribe button and spread the word. It covers pretty much most of what we've talked about here. And on Tuesdays and Thursdays, new short little videos, they're 7 to 10 minutes long, they drop. I'd really appreciate the support. And there is a talk about how to do a carnivore diet. But I really appreciate everything, Sean, and thanks for the great work. And thanks for being the experiment that proved to us that carnivore is safe. That really is what I value about what you've done.
Yeah, thanks. And also your Instagram is Carb Addiction Doc, I think, as well. So follow Robert. Like I said, let's all support each other as this community grows. We need to become stronger, and let's just keep doing the right thing. All right, guys, I'm going to end this. So everybody, much. Tomorrow we have Mark Bell coming on, another good person battling for the right side of the things. All right, guys. All right, have a great day, guys. Take care. Bye-bye.